Prateek Sharma from Kansas City, and it's my pleasure to give you an update on Barrett's esophagus 2013, whether to screen, survey, ablate, or ignore. This is based off the presidential plenary lecture on the same topic. First and foremost, I think it's important for us as gastroenterologists to make an appropriate diagnosis of Barrett's esophagus. So the first issue about ignore, what patients, what lesions to ignore, what's very simple are those who have a normal squamocolumnar junction or a normal Z-line. Even those individuals who have an irregular Z-line, which can be defined as a tongue which is less than a centimeter, have a very low chance of progressing to high-grade dysplasia or cancer. The kappa value for endoscopists to recognize a lesion like that is less than 0.2, which is really poor. So these areas are best left alone. So that's the part of the lecture which says you can ignore these patients. Next, if we move to nondysplastic Barrett's esophagus, what we have determined over the past 2 decades is that the cancer risk in these patients with nondysplastic Barrett's esophagus is not 1%, 2%, and not even more recently, which was shown as 0.5% a year. But recent evidence suggests that it's more in the range between 0.2 to 0.4% per year. These patients are currently surveyed until we get better risk stratification tools. There are a number of endoscopic and biomarker tools which are being evaluated for these patients. Low-grade dysplasia is a moving target. So the recommendation for that is rebiopsy these patients, relook, do a careful examination, make sure you're not missing any visible lesions, and then have a second pathologist look at the biopsy because that will really confirm the diagnosis. Series show that up to 80% of patients who are labeled as low-grade actually in reality don't have low-grade dysplasia. Finally, high-grade dysplasia and early cancer or mucosal cancer. These are the patients who have the highest risk of invasive adenocarcinoma, and these should be treated endoscopically if they choose this path. Mucosal resection followed by radiofrequency ablation is the current treatment of choice in these patients, and that's what should be recommended for them. Recent data also presented at DDW show that recurrences are common after endoscopic ablation, up to 20 to 25%, and so you need to follow these patients carefully in surveillance programs. So that's in summary what I would recommend as what patients should be ignored, what patients should be surveyed, and what patients should undergo endoscopic therapy. Thank you.